So Dr. Mariya Banu, and I'll also invite Dr. Harsha on the other podium. Yeah. Dr. Nibha is there. Dr.
Very good.
Mariya Banu is going to talk on Tale of Two Traumas, Visual Outcome in Closed Globe Injuries with and without head trauma.
A very good morning. I thank the scientific committee for giving me the opportunity to present my work once again. I thank my respected co-authors for being with me. Ocular trauma has a wide variety of presentation ranging from contusion to globe rupture and the patient presenting with a vision of 6/6 to patients with no PL. The aim of a study was to analyze the influence of head trauma in the visual outcomes of patients with ocular trauma. It was a cross-sectional study with a study duration of 3 months. We included 300 patients with closed globe injuries attending both our ED and ophthalmology OPD in a tertiary care hospital. We subdivided the 300 patients into two groups. As first group, which had 150 patients who presented with both an ocular trauma as well as a head trauma. And the group 2 patients had only an ocular trauma, which was a closed globe injury. The age group which was included was 18 to 65 years and the 300 patients as mentioned earlier. Exclusion criteria: patients with severe head trauma with GCS less than 9 and open globe injuries were excluded from our study. The visual acuity during the first admission after trauma and at the end of 2 months was recorded. There were several concomitant factors like head injury, a lid injury and bony orbit was documented, and we analyzed whether they had a effect in the visual outcomes in both the groups. Results: coming to the demographic data, the predominant age group in both the group 1 and group 2 was less than 30 years, and majority of our population was only the male gender in both the groups. This graph shows the various causes of closed globe injuries, which shows that both in the group 1 and group 2 the major cause of trauma was a road traffic accident, and this summarizes the various ocular manifestations with which the patient presented. The highest was papilledema in our study in group 1. We also further analyzed whether there was an impact of GCS on visual outcomes. So this table shows that the patients with a moderate head trauma of GCS 9 to 12, approximately 38.9% of the patients had an improved visual acuity more than 618, whereas patients with a mild head trauma, which is GCS more than 12, about 56.5% of the patients showed an improvement in visual recovery. We also analyzed whether the visual outcomes in patients with papilledema in group 2, in group 1 it was about 27.3% of the patients had a visual recovery of more than 6 by 18, whereas in group 2 it was 100%. The 5% in the group 2 had papilledema, which could be probably explained by the bilaterality of the ocular trauma. The exact origin of the papilledema may be due to an head injury which was not evidenced by any radiological investigations. Incidence of RAPD was also taken into account. In group 1 it was about 42 patients who presented, whereas in group 2 it was 21. Further, we analyzed how does RAPD affect the visual outcomes in patients. In group 2 the total was 21 patients, and we see that it was an intraorbital injury or canalicular injury to the optic nerve. Of these, 6 people did not show any improvement and 15 showed improvement. We also did an optic nerve decompression was done surgically, but visual outcomes did not improve for the 2 patients. We also saw whether there was a concomitant bony orbit involvement which is affecting the visual outcomes. In group 1 it was a blowout fracture which was most common, whereas in group 2 it was a medial wall which was the most common fracture, and it also shows the visual improvement. Visual outcomes in patients with lived improvement: approximately 56% of the patients in group 1 and 75% of the patients in group 2 showed an improvement in visual outcomes. So coming to the final discussion and summarizing all the things, presence of head trauma in patients with papilledema had a poor prognostic factor and it was statistically significant. Presence of RAPD in patients with head injury had also had poor visual outcomes, which was also in correlation with the previous literature studies which showed that RAPD grades were also associated with poor visual outcomes. We also found that bony orbit involvement affected visual outcomes in both the groups, but results were statistically insignificant. Lid injury was also noted and the results were statistically significant. Coming to the conclusion, we conclude that head trauma, when happens along with ocular trauma, has a basically important prognostic significance. GCS score is important factor in assessing the general prognosis. Presence of papilledema in the presence of head injury is a grave prognostic factor. RAPD in association with head trauma is an ominous sign. Bony orbit involvement, if present along with a concomitant head injury, decreases the visual outcomes, even though it was statistically insignificant. Lid injuries do not decrease the visual outcomes, irrespective whether there is a concomitant head injury or not. So we conclude that papilledema, RAPD, and bony orbit involvement are the factors which predicts the visual outcomes in patients who present to you with a concomitant ocular trauma as well as a head trauma. These are my references, and thank you.